Testing, testing, testing. I have to speak all the way in, Eric. Is there any way to? Okay. All right. Can everybody hear me? Okay. Good afternoon. Good afternoon. We're still waiting for folks to sort of trickle in, but we're going to go ahead and get started. We have a packed program today, and we want to make sure that you get as much time with our guests as possible today. So good afternoon, everyone. Good afternoon.
Good afternoon.
I am Donna Ennis, the project director for the Minority Business Development Agency, or as we call it, the MBDA Business Center. And it is so good to see so many of you here today. This is a very exciting time for us. And my staff and I are really pleased to be able to bring you this program. We have planned, as I've mentioned earlier, a program full of information and networking with some really heavy hitters from the healthcare industry. And it is our goal for you to walk away from here today with next steps for building relationships and ultimately pursuing business opportunities. But before we get started, I'd like to share some thoughts with you. First, I'd like to thank AGO Resources for supporting our MBDA Business Center over the years. We've had a long relationship with them, and they've been one of our major corporate sponsors. We'd like to thank our strategic partners who have provided lots of programming support and our stakeholders who advocate on behalf of the center. But certainly certainly not least, we'd like to thank you, our clients. We really appreciate you for utilizing our services, allowing us to be a part of your team, and believing in our ability to help you grow your company. I'd also like to thank our guests here today who have committed their time and resources to be here to talk to you about the healthcare industry and the vast opportunities available, and to meet our clients to build relationships with the goal, again, of securing business. It's hard to believe that 10 years ago, on January 14th, we opened our doors for business. And as I've kind of moved through this talk, I'm going to sort of skim through our presentation here. Am I doing this right, Alicia? No? Apparently I'm not.
Right.
You hear me call Alicia? Sure. What do you need to push this here? Or this? Okay. Thank you. See our newspaper? Woohoo! Yeah, it's hard to believe that 10 years ago on January 4th, 2004, we opened for business. We became part of what is now a national network of about 50 centers, all with the mission of growing and strengthening minority business enterprises, or MBEs. Can I go back? Okay, there you go. Okay, stay with me. Okay, thank you. Funded by the Department of Commerce, Minority Business Development Agency, or MBDA, Georgia Tech, the state of Georgia, and our clients through subsidized fees, the MBDA Business Center has been able to help hundreds of clients over the past 10 years secure over $1 billion in contracts, sales, and financing, build stronger businesses, and create thousands of jobs. And we've been able to touch and guide thousands of MBEs in this process, and other businesses as well. I must say that when I look back on what we have been able to accomplish with the help of so many people and organizations, I know that we are in the right place, doing the right thing at the right time. This timeline is just a sample of some of the milestones our clients and the center have been able to achieve, and I'd like to share just a few of those with you. In 1969, MBDA was established. It is the only federal government agency with the mission of helping MBEs grow and thrive. We opened our doors in 2004, and by 2007, Not only was the center consistently recognized for top performance, but one of our clients completed an acquisition, and another one who's here today, ARS Mechanical, won the Regional Construction Firm of the Year. We periodically must rebid for the center, and we won our first rebid as well. 2008 was another year of success for our clients. With our assistance, Dover Staffing won the Georgia statewide contract for temporary services, and that was the first time we'd ever worked on a statewide contract. And Lord and Dominion won a $60 million contract with HUD. The center was also named as AGL Resources Development Partner, helping them develop companies in their newly established Mentor Protege program. In 2012, we launched our Health IT program with Yvonne, who will talk a little bit about that later. And last year, we established the Health Technology Action Collaborative, or HTAC, the center's first teaming program with 6 companies that are committed to working together as a team to pursue opportunities in healthcare. We have some of them here today. If they're here, please stand as I call your company name. Accenture, ICAT, Global Resource Management, Inc., Cyberus, TechMasters, and QTS. Let's give them a hand for their commitment to collaboration. We're really excited about this program. They have really committed to collaborating as a team to pursue opportunities in healthcare. As we look forward to the next 5 years, the center has embarked on a strategic focus that we believe will continue to grow our companies and at the same time take the center to the next level. We realized that we spent the first 10 years developing a strong foundation and that we'd like to focus the next 10 on building upon it. Thus, we are moving toward client and industry concentrations. Just as we coach you, our clients, to have a strategy where you hone in on customer sets and industries, we're practicing what we teach. Here, you see our focused customer sets: professional services, which include logistics, staffing, marketing, and event planning, IT and telecommunications, telecom, construction, manufacturing, and technology. Coupled with 4 major industries, healthcare, transportation, energy, environmental, and education. All of this, am I going too fast? Transportation, sorry about this. Energy and environmental, and education. And all of this is set against the backdrop of helping our clients go global where possible. Helping U.S. companies go global is a major focus of the Department of Commerce and MBDA, and we have aligned our center with this focus. As I have traveled to a few countries over the past couple of years on business, I have seen the phenomenal amount of opportunity that exists outside of the U.S. We will also work more closely with our corporate and strategic partners to bring more resources and expertise to our clients, and we'll seek new partners to work with. So if there's anyone from this list today, is Restaurant, are they here? Of course, the Healthcare Supply Diversity Alliance is here. Deborah, I'm sorry.
All of us.
And
yes.
all of you are part of the Healthcare Supply Diversity Alliance.
We'd love to have you as well.
Thank you for your support.
Thank you.
The other assistance that we will acquire more experience with is acquisitions, as we believe that this is a viable growth strategy for our companies. For example, I am happy to announce that we assisted, if you know, Adam Walker with Homestead Packaging Solutions, and just recently he completed an acquisition of Summit Container Corporation, another packaging company. So we really hope to do more of these in the coming years. We're celebrating a decade of success in a number of ways, and we're really honored to have you here with us today. We're launching our Business Opportunity Series today. This program will bring industry and global opportunities to you through face-to-face meetings and programming such as today, webinars, small group meetings. Our next meeting in this series will be sometime in late May, early June, and will target MBE manufacturers in the supply chain with a focus on advanced manufacturing. So please stay tuned. This year, we also launched our Connecting Advanced Manufacturing program, which, much like our healthcare program, which you'll hear about later, brings MBE manufacturers together in a community to strengthen their businesses, utilize advanced manufacturing technologies, and seek, again, business opportunities. So as you can see, much has been and is happening here at the center. We have steadily increased our impact and will continue to focus on the result. So what's next? Number one, we want closer client engagement. We are building our virtual and electronic media and communication channels to bring you more value-added information and programming. We have redesigned our website, launched our monthly newsletter called The Pulse, and with Alicia here, we're building our social media platform. I'm actually tweeting, not right now, but I'm actually tweeting these days.
Oh, that's good.
And believe me, those of you who know me, that's a really big deal for me. And we will continue to host special events as the need presents itself, particularly as they relate to technology, going global, and securing opportunities. For example, in this picture, one of our companies is a beta tester for Google Glass. And so they came in with a number of our clients and other companies to talk about Google Glass and what its application is in manufacturing, healthcare, and construction. Our number 2 focus is programming. We have 5 programs that we'll be focusing on to help you grow your business. I want to stop here, though, and just say to you that even if you're not working in these particular industries, that doesn't mean that we are still not going to serve our clients. It just simply means that as we coach you guys, that this is where our focus will be. This is where we'll be spending a lot of our time and attention. So one is Going Global. Stay tuned for our Going Global program. We have a lot of resources from the Department of Commerce, the International Trade Administration, and so we'll be pushing out a lot of that information to you, as well as sponsoring our own programming for that. Our Business Opportunity Series, which is here today, and we've launched that officially today. Our CAMP program, which is Connecting Advanced Manufacturing. Our Healthcare Partnering program. And then finally, we just launched a student internship and ambassador program. And the internship program, over the years, we have had a number of requests from you guys to utilize interns and students in your business. So we've decided to launch a formal program where we can bring you resumes and things of Georgia Tech students. So we'll have more information about how to do that. But basically, there will be a need for you to provide us with a job description, the amount that you'll pay the student, or if you want it as a special project, for a curriculum or for credit, and then we'll put it out on the wire, get you the resumes, and go from there. These programs, again, are designed to keep us focused on our industry and customer concentrations that I mentioned earlier. Our student internship program, as I mentioned, will make the Georgia Tech students available to you. Finally, we want to report your success. We will highlight a client each month through a success story, so please let us know how our assistance has helped you be successful. Here are some examples of some of the client success stories. Charles Weems is here, Ken Towton is here, and then we highlighted Latimer Communications. Not necessarily in a success story, but they just recently won a really big marketing award, and we thought it was important to push that information out. So it's not just about a success story, but if you're winning awards and you have a story to tell, let us know, because we want to be your advocate and we want to be able to push that information out. Finally, as I wrap up here, I would like to introduce and thank my staff for their hard work, dedication, and commitment to the center, its mission, and our clients. This is really a team effort. In addition to our staff, we have so many people behind us that have been behind us, just giving us resources, time, and attention over the years. Please stand as I call your name. Maria Hill is our senior business advisor, who handles our finance projects and will be working with me on developing the Going Global program. Yvonne Dragon is our program development specialist, who led the development of the healthcare program and is now working with me on the manufacturing program. Alicia Williams is our newest member on the team. She's handling our marketing and event planning and has been focusing her immediate time and attention on our social and electronic marketing presence. And what we will ask of you is that you provide to us feedback, and we'll send that to you. But we want to know how you want to be communicated to, because some of you read the newsletter, some of you like a personal email, some of you want a phone call, very few of you want a phone call, but you know, we really want to know how can we communicate effectively with you, and our goal is to make sure we reach you that way. Sanji Barker is one of our student interns. Is Sanji in here? She's out on the front desk. She's one of our student interns who is leading our database development project. And then we have Brandon Miller, who is also a student intern who focuses on the research needs of the center. We also have two students out front, Eva Zajanovic and Brandon Dupree. And they're our new ambassadors. This is the first time that they've joined us as ambassadors just to help us with the program. So let's give everybody a hand. So now I'll turn the program over really quickly with Yvonne, who can provide a backdrop for the healthcare program before we bring up Glenn. Thank you.
Thank you, Donna. Good afternoon.
Good afternoon.
All right. So I was thinking last night on what I wanted to start the presentation out with, and I wanted a quote, and I said, where can I get a quote from? My spiritual leader, my pastor, my grandmother who's 95 and always has sage wisdom, and I said, no, the internet. That's where I'll go. So I found a quote to kind of put things in perspective, and the quote is from Karen Hawkins, and I'm not familiar with her, but I'll give her credit where credit is due. In order to understand something really and truly well, you must know where it came from. There is no other way to appreciate its value. So I'm going to kind of give you context into the healthcare program and where we're going, okay? So in the beginning of our healthcare initiative, we launched in 2012 as part of a tri-agency grant between the EDA, ETA, and SBA. And it was awarded by the Obama administration. Georgia Tech won because we are at the center of a cluster of health IT firms in the United States. We're touted as the health IT capital of the country, if you didn't know that. The program initiatives that we centered around were three concepts: teaming, education, and innovation. With teaming, we created the HTAC Selective Teaming Program focused on pursuing health IT opportunities, and this group meets every 2 weeks. So if you have any questions about that, you know who those HTAC members are, and we appreciate your efforts and your commitment. Education, we have partnered with ATDC and the healthcare group at Georgia Tech to host monthly meetings in which business owners can learn and discuss how to grow their business in the health IT space. And lastly, innovation. Donna touched on this a little bit. We launched our Mastermind series, which is a peer-led discussion around opportunities to spur innovation and create disruptive technology. Many of our companies have actually presented content in these platforms, content, case studies, and technologies. If you have presented at a past event, please stand up at this time. Kevin, Charles, Melba, Charles. Am I missing anybody? Okay. Well, so the intent of having these platforms are not only to engage our community and to provide information, but to put these individuals on a platform where they can leverage these speaking opportunities and use it to draw business to them. So we thank you for your participation. So how else do we engage our clients? We do it through pre and post event networking, which we need more of that, and hopefully you'll get that today. Social media, which that's what it's very much. Virtual introductions, which that's ongoing. And if you don't introduce yourself to somebody today and you want us to introduce, please let us know and we'll make that happen. One-on-ones and group outings. So what have been the results? We've created a virtual community through Shutterfly that includes over 70 individuals representing 50 firms. It's a pretty rich ecosystem. We have achieved over $6 million in contracts. I shouldn't say we, our clients have. And over 10 partnerships and close to 20 jobs created or retained. So what's the future scope of the program? Increased synergies and partnerships, more presence in the healthcare space from our clients, more leveraging of the Georgia Tech brand and the MBDA Business Center in Atlanta, and of course, most importantly, more contracts and more business. And the sky is the limit. So I'll leave you with one more quote, and this one is well known, and it's by James Baldwin. Know from whence you came. If you know whence you came, there are absolutely no limitations to where you can go. Thank you.
So thank you very much. Again, we wanted to thank AGL Resources for being our sponsor. And without further ado, we're going to move on with the program. This is our official launch of opening up our healthcare program from the IT sector to all of our customer sets. So going forward, aside from partnerships that we have with groups that are focused on IT specifically, you'll still get the information, but most of our programming will be for all customer sets. We may do some very specific things like healthcare, manufacturing, or construction, or that kind of thing. But for the most part now, it's officially open as to all of our customer sets, if you will. So without further ado, I want to introduce our guest speaker today is Glenn Pearson. Glenn is the Executive Vice President of the Georgia Hospital Association. He's board certified in Healthcare Administration and is a fellow in the American College of Healthcare Executives. He has a long, illustrious bio on his many, many accomplishments and his touches in the healthcare industry. And he provides leadership in many areas for the Georgia Hospital Association, including financial services, Medicaid, Medicare, Georgia Hospital Systems, Public Relations, and Communications. And just really quickly, prior to moving to GHA, he was Vice President of Data and Shared Services for the Hospital Council of Western Michigan in Grand Rapids. We welcome Mr. Glenn Pearson as our
You can tell them that I'm a professional blues harmonica player. Yeah, I've done projects right across the street at Turner Broadcasting and Six Flags and all that, but I didn't bring a harp with me today. But anyway, thank you so much for having me here. I'm very impressed by this group. I didn't know you guys existed, and it sounds like you're doing some really good things. And you know, from my perspective, this is a perfect group for me to come to speak to, because one of the things I do is look for technology application solutions that we can introduce to the hospitals in Georgia. So I'll say a little bit more about that when we get there. I forgot to bring a laser pointer. Does anybody happen to have one that I can borrow?
We got interns.
Oh, we got one.
Right.
There we are.
You know, I'm disappointed I didn't know Alicia was here. I was going to have her help me with swirling. This is just a dumb old PowerPoint, so it's not real exciting. All right, don't be afraid. This is what I'm going to talk about. There's a lot to cover, but every one of these points is pretty quick. First, I'll give you a word about who GHA is. Then I'll talk a little bit. My understanding is that what you want to know is what are the opportunities within healthcare and specifically in the hospital climate for technology applications, technology solutions. Is that pretty close? All right, well, it better be, because that's what you're going to see. All right, so in order to understand that, you need to understand a lot about what's going on with hospitals, and I'll talk a little bit about the positive impact that hospitals have on the economy. And then follow the money. You know, it always comes down to that. There's a lot going on, most of which is not good for hospitals, so we'll talk through that briefly. Then we'll look at the impact of what that means of these problems up there. Mention briefly the regulatory climate, mention briefly quality and patient safety issues. We also have a personnel supply issue that we're dealing with in healthcare. And then electronic communications, which is, you know, getting closer to where you guys are at. And then finally, just a couple of comments on the opportunities and how this all could work together. So first of all, who's GHA? We're founded in 1929. We're the statewide trade associations for all the hospitals. We're very proud of the fact that we have all 170 of Georgia's acute care hospitals as members of GHA. It's voluntary. They pay us money, so if we weren't doing good things, they wouldn't pay us money. So we have everybody there. Our goal is to promote the health and welfare of Georgia's citizens by supporting hospitals in their missions to provide the most cost-effective and highest quality care possible through a bunch of different things. Representation at the Georgia General Assembly and U.S. Congress, assistance with regulatory compliance, educational programs, quality initiatives, data services, and then programs and services to assist in hospital operations. And toward the bottom is where I spend a lot of my time. I'm doing a lot of work with the whole mHealth, digital health, whatever you want to call that. I'm actually the treasurer for the Georgia Statewide Health Information Network, which is something we've been working on for 10 years. Christopher's been helping us with that too. So, that's where my heart is in terms of trying to make a difference in the field. All right, how do hospitals help the economy? A lot of times, of course, you think of hospitals as the providers of care, which is what our primary mission is, but we also bring a lot of economic value to the communities that we work in. So, you have hospitals. There, okay. So you have hospitals, you have insurance companies that pay hospitals to provide services. So we buy stuff and we hire people. So then when you buy stuff, there's sales tax involved, goes into the state treasury. When you hire people, they have a salary, it goes in income tax. Buildings for for-profit hospitals pay property taxes, and they buy services from other people. A lot of it goes back into the government treasury, but it also turns into, the money turns around a couple of times. So if I pay my banking company for my mortgage, so they make some money off that. When I buy gas to drive to work, the gas companies get that. So for every dollar spent in going towards pay for hospital services, turns around 228% of the time, or 2.28 times turnover. So besides being an important asset in the community, we're also an economic asset to keep the economy moving. Here's what's going on with payment in hospitals. It all comes back to the financing, and a lot of these are a little bit hard to see, so I'll point out what some of these are. This left-hand side looks at the percentage of people that are covered. This counts the number of people. The right side counts the revenue, how much money comes from that. So from the covered side, you can see that more than half of the state's population has health care coverage paid for by the employer. So it's 52%. I better put my glasses on. Medicaid accounts for 14% of the population. Medicare is another 12% of the population. And then unfortunately we have 19% that don't have insurance at all. So most of the residents of the state are covered by their employer. About a quarter are covered by government plans, and then about 19% uninsured. Now in terms of revenue, obviously you don't get a lot of revenue from people without insurance. So the way it breaks down, you can see that Medicare, it's only 12% of the people, but it's 36% of the dollars come from Medicare. Medicaid is about the same, about 14% in both cases, and employers is about 40%. So there's a difference between the number of people covered by different plans and the revenue that actually comes from that. So what I want to do is briefly go through some of the highlights of what's happening in these major categories so you'll understand some of the challenges that hospitals are facing right now. This shows the operating margins from Medicare. So what this does is it looks at how much money, this is for statewide collectively. It's going to vary by each hospital. It's going to be somewhat different. But if you add up all the dollars that hospitals got from the Medicare program, taking care of Medicare patients, and then you compare that to how much money they spent doing that, what's the difference? That's called margin. So it turns out that back in 2000, there was about a 3%, 2.6% margin. So we made a little bit. For every dollar you spend, you make a couple pennies, okay? You can see that it went down, and actually in 2002, it started cratering further. It bottomed out in 2006 at negative 5%. So what that means is that for every dollar you spend taking care of a Medicare patient, you only get 95 cents back. Okay, now think about that in the context of your own business. How happy would you be if every time you turn around and you spend some money taking, developing a project or servicing a client, you lost 5 cents? That's not good. Well, hospitals are pretty adaptive, and they're able to begin to turn things around. And you can see that the negative margin got slightly less, until we're almost back at break even in '09. But look what happened. We're back down there. Okay, what happened in 2010?
ECO?
Close, ACA, Affordable Care Act, healthcare reform. Half of the money to pay for the healthcare reform bill is coming from cuts in Medicare. $500 billion over 10 years is being cut from Medicare to pay for Affordable Care Act. So we saw the beginning impact of that in those years, okay? Now this shows projecting forward what that means. So we stopped at about 2012 on the previous slide. This shows what happens in 2013 and beyond. 4% cut in 2013. We're currently in 2014. That's off the baseline of 2010, okay? So 6%, 9%, 10%. So this is bad news. This is the amount of money that's being cut from Medicare from hospitals to pay for the Affordable Care Act. And these are the dollar amounts that are represented there. So that's what's happening with Medicare. Not a good situation. Let's talk about Medicaid. All right. Similar situation, only in some ways worse, or started out worse. I don't know if it's going to get worse or whatever. But anyway, there are different categories of payment for Medicaid. I'm going to go on this side. Okay. There's inpatient care and outpatient care. The FFS is fee-for-service. That's traditional medicine. You go in, you do something to get paid. Then they have CMOs, which are management organizations, more like HMOs, managed care. Oh, I'm sorry. Thank you. All right. Back to the mic. So this shows for inpatient and outpatient, the percentage of cost coverage from these different categories. So on the inpatient side, on the fee-for-service side, this is based on 2012 data, hospitals only got paid 92% of what they spent for Medicaid inpatient fee-for-service, okay? Managed care, they only got 85%, okay? On the outpatient side, on the fee-for-service side, they only got 80%. So they're losing 20 cents for every dollar they spend, okay? On the managed care side, they're losing 81 cents. So if you add it up and do a weighted average, all the Medicaid volume, we're losing 13 cents for every dollar we spend. Now let me give you an analogy. Let's say that you're the owners of a road construction company here in Georgia, and the state says, you know what, the interstate's looking pretty bad. We need to, repave I-75 up to Chattanooga from Atlanta. And because you're in Georgia, we want you to do the job. In fact, you have to do the job. And we'll even pay you 87% of what you spend to do the job. What a deal. Who wouldn't want to do that? But that's really the situation hospitals are in because, we're here to serve the public, and we're required to take care of everybody that walks in the door, and we're losing 13 cents on the dollar for every Medicaid patient. Okay? Let's look at the uninsured, which is a major problem. 1 in 5 Georgians, or 19%, is uninsured. Unfortunately, we rank 5th highest in the nation in the number of uninsured people, and 1 out of 8 children in Georgia has no insurance. So that's a major problem. It's a problem for them, of course, in terms of getting health care services, but also creates problems for people that are providing care, like the hospitals and the physicians. Okay, now there is a supplemental program called the Disproportionate Share Hospital Program, which is designed to make up a little bit of the shortfall from taking care of uninsured patients and the shortfall from Medicaid, the 13% that they lose. Unfortunately, it only covers about 20% of the shortfall. So it's a little bit of help. If I don't have the numbers in front of me, but if you lose $100 million, it's about $20 million you get back to make up some of that difference. You're still losing $80 million. So it helps a little bit. But unfortunately, again, under the Affordable Care Act, the theory was that you would have fewer uninsured people because of the expansion of insurance coverage, and therefore you wouldn't need as much money for the supplemental program. So that's being cut. So this shows what the cuts are for the DSH programs, what we call the disproportionate share hospital. Nationally, in 2013, there's $11 billion. Georgia got $282 million of that. But then look at the cuts that are coming underneath that for over the next year. So in 2014, we're experiencing a $500 million cut nationally, $11 million to Georgia. It goes down to 13, keeps going down and down and down. So not only are we losing money taking care of Medicaid patients and providing care for the uninsured, this program that's designed to help a little bit with make some of that up is not heading in the right direction. So is everybody happy yet? What this results in is the need, you probably, think about your own businesses. If you're losing money on significant portions of the people that you're working with, like Medicare, Medicaid, and the uninsured, collectively that represents up to, for some hospitals, as much as 75% of the people that they treat. So if you're losing money on 75% of the people that you're working with, you have two choices. Either quit doing business because you can't do that forever, or you get someone else to pay for it. And that's the situation we're in. This chart's a little bit complicated. It shows, for the different categories, this shows the percentage of the patients. So Medicare represents about 25% of the patients, and we're getting on average about 96%. So that leaves a 4% gap of loss that has to be made up. Medicaid represents another, roughly quarter, and we're losing 89, or we're getting 89 or 87% roughly in that area. So that leaves about another 11% of that group you have to make for. On the insurance side, you get about a quarter of what you spend, either from the little bit you get from the uninsured or from the supplemental programs. That leaves a gap of 75% that needs to be made up. So all this striped gray area is the part that you have to make up for by the blue area on top of the line. The 100% line represents 100% of cost. So this amount up here is what's keeping afloat this other part. So that's a crazy way to do business. So any of you, all of us who have insurance through our employers, part of what I'm paying for is for these shortfalls that aren't covered by these other programs. Okay? So let's look at what's coming under the Affordable Care Act, and I don't have a lot of time to go into that, but this is something that's and it's not just the ACA. This is happening in the private insurance market as well, the state health benefit plan. And a lot of you guys are probably covered by state health benefit plan, I would think. You're having higher and higher deductibles, which means there's more and more responsibility that you have to take on yourself, which means hospitals have to get in the business of collecting money like they didn't have to so much in the past. So, for example, my wife's a teacher at Paulding County, and it used to be she had no deductible, and then it went to $500 deductible, and then this year under open enrollment, the lowest deductible for an expensive plan was $1,500. The gold plan. Then they had so it's different from the ACA gold, silver, bronze, but the same idea. So the gold plan had a $1,500 deductible, more expensive. You can save a little money on your premiums by going to the silver plan, which had a $2,000 deductible, or if you wanted to save more money on your premium, you went to $2,500 deductible. So 2 years ago, my wife had zero deductible. Now she's at the silver plan, $2,500. Fortunately, we've been blessed financially, and I can afford that. If she needs care, I can come up with $2,500, but not everybody can. If they don't, then the hospital doesn't get paid. So, and that's parallel to what's happening under the ACA as well. Here's the platinum plans with a 10% premium cost share, and then gold is 20%, 30%, 40%. So this phenomenon of higher and higher, these were part of the people that were keeping things afloat, people with private insurance. That blue line above, if I can go back, the blue line above that is what was keeping this other part afloat. Well, this part is eroding because there are more and more people who are having higher deductible plans, which means that, they may or may not end up paying for that care after all, which is going to make it tougher and tougher for providers to keep their doors open. So what's the impact of all this in terms of the financial climate? That's the backdrop we're in. So what does this mean to hospitals? Okay, This shows the amount of money or the numbers of hospitals that are losing money in Georgia in the current climate. So this is 2011 data. It's a little bit dated, but it hasn't changed a whole lot. So of the 170 hospitals, 51% lost money in 2011 on what's called patient care margin, which is looking at how much money they got for taking care of patients versus how much they got paid for taking care of those same patients. So more than half of the hospitals lost money in their core business, which is take care of patients. Now, fortunately, there are other sources of revenue. You know, if the stock market's good, you get a little bit of, you know, interest income and all that, and you make a little money off the gift shop and parking, you know, whatever. So if you take that into account, that helps a little bit. Only 38% lost money off everything, and that includes the supplemental payment amounts as well. So more than a third of the hospitals lost money overall, almost 4 out of 10. And it's even worse for the rural hospitals, 66%, two-thirds lost money taking care of patients, and more than half lost money overall because of that crazy chart I showed you with the bars that aren't covering the cost. And this shows trends in the overall hospital margins. Again, the red part shows the patient care amount. So in 02, again, this is for all the hospitals. If you add them up across the state, you know, treat them as a single hospital, which of course they're not, the overall patient care margin was a negative 1.5%, brought it up a little bit, and it got, you know, never did reach 1%, and then bottomed out. And, you know, now, then when you take into account the other amounts, the highest it ever got in the recent past was 3%. Most businesses will tell you, unless you're making 5% margin, you're in risk of having problems long term, because you got to put money in the bank to, you know, buy new buildings or, you know, replace technology, whatever. And that's the average. So that means some are doing better and some are doing worse. And I already showed you that, you know, two-thirds of the rurals were losing money from taking care of patients. So this is the climate that hospitals are operating in. Let me stop. I just have a few more slides. Let me just stop and see if you have any questions or reactions. So it's not an easy climate to do business in.
Yeah, I'm so the insurance companies are paying more than they really should be.
Yep.
Why do they agree to that?
The question is, the insurance companies are paying more than they have to. Why are they doing that? Because they have to. Because hospital wouldn't be, and this goes for doctors too. Yeah, we'd be out of business if they didn't. You know, and yet, like I said, even with all that extra amount they're paying, you can see that hospitals are barely hanging on by their teeth. So imagine if they weren't paying that amount, there wouldn't be any hospitals. Yes, sir.
Do you see the current hospital systems changing their template or their strategies? I mean, you know, ACH is on the premise of like European, Canadian countries and how you do the hospital system. Do you feel that here in the United States, hospital systems are going to be forced to change outside of trying to do shortcuts, like, you know, change the payment systems for doctors? I mean, those are overheads that the systems have, the hospitals have, where if they reduce some of those costs and the expenses that they pay their doctors, those costs might be, you know, subjugated to other areas to balance out, like, you know, European countries.
Yeah. Back 35 years ago, the federal government changed the Medicare payment to something called prospective payment, DRGs, if you've heard of that term. And that was really the first step in that direction. So hospitals have been trying to do that for the last 35 years. And there's plenty of room to go. I'm not saying that we're the most efficient organizations on the planet, but there's only so much you can do, you know. And unfortunately, when a lot of times when hospitals have improved their efficiency, the response is, well, you're starting to make money again. Well, we can cut some more from you because you figured out how to cut your costs before. So the answer is yes and no. I mean, there's always more that can be done. There's some fundamental problems with this, with the way we're paid for right now.
In your opinion, and I'll only ask because I'm a consultant, you know, staffing, do you feel that the systems are changing to some more contingent type systems in clerical nursing, as well as some of those specialist doctors, instead of having a full-time doctor, they're going to trying to hire?
No, I don't think so. I mean, they're pretty flexibly staffed right now. I mean, there's not a cadre of nurses standing by empty beds hoping, you know, if somebody gets sick. I mean, we're adjusting, you know, all the time. It's just a very, very challenging climate.
And one last thing, and
Yeah.
this is one of the things that's kind of been bothering me since I was a child, going to the hospital numerous times, is do you think one of the biggest issues is that you have some of the same patients coming back to the
Yes.
door over and over again instead
Yes.
of having good, pure care to make
Yep.
sure that you solve the issue that the
Yep.
patient
Yeah.
has?
That's an excellent point, and that's one of the really good things coming out of the Affordable Care Act is the incentives are changing to coordinate care much better than it's been, and that's wonderful. And we're starting to see that flow through, which is a really positive thing. Now, the other half of that, which isn't always so popular, is that a lot of the patients have self-inflicted readmissions. You know, so for example, if I am diabetic and I'm in the hospital and then I'm discharged to go home and I stop by Kroger on the way home and pick up a couple boxes of Twinkies and I'm back in the ER the next day, the hospital is being blamed for that.
Right.
The hospitals are being penalized for readmissions within 30 days of a discharge. And to me, I'm incensed by that. There's no patient accountability. Right. Patients, it's a two-way street. You know, it involves everybody. So yeah, hospitals can do a better job, doctors can do a better job. We need to coordinate better, which is starting to happen, but you're exactly right. In fact, I didn't have time to show this, but there's a CDC study I love to show. The CDC did this study in 2002. It shows what are the underlying causes of people dying early. And that's a surrogate for health status. So in other words, what contributes to my health status? By far, the single biggest factor at 40% was lifestyle choices. So if I'm smoking, if I'm grossly overweight, if the only exercise I get is going from the couch to the pantry to get a food that ends in Edo, you know, that's not a good thing, you know? So there's nothing that makes me take care of myself. 30% of my health status is depending on my genetics, you know, and I can't help that. So there's so much beyond the control of the providers, and we're being blamed for, I sound like I'm whining, I am, I guess, but, you know, everybody has a part is what I'm trying to say. You know, we're happy to do our part, we're happy to recognize we need to do a better job, but we really need patients to engage and follow doctors' orders, follow orders when they're given prescriptions to fill them and take them so that they're not back. And it's a very complex situation. So thank you for letting me rant for a second. Yes, sir.
I had a question about leveraging technology. As a business owner, we're paying for the
Yep.
So where do you see potentially using technology, using this to help business owners force change to help them save money?
That's a great question, and that's kind of where we're going with this whole thing. And that's, by the way, if any of you have, one of the things I do is look for companies we can present to the hospitals in Georgia. So if any of you have a viable hospital-facing service that you would like me to take a look at, I'm happy to do that. But a lot's going on with mobile applications and with, you know, monitoring on iPhones and iPads and all that stuff, Bluetooth connectivity and all that. So yeah, that's what I'm very optimistic about. I was telling Christopher before, I think there's a lot of good things going to be happening in healthcare over the next few years because we're beginning to harness that to do exactly what you said. Let me just run through my last few slides here. This is an impact slide. I don't expect you to read it. It just shows how many people are regulating hospitals, like everybody. Some of you may be and you don't even know it. But so we have to comply with lots and lots of regs. Okay. There are some really good quality and patient safety initiatives out there to try to deal with some of these questions. GHA established something called the Partnership for Health and Accountability about 15 years ago to provide education and data-driven tools to help improve quality. We work with hospitals. We're one of only 26 organizations in the country to be what's called the Hospital Engagement Network, trying to help hospitals, you know, improve their quality standards through statistical feedback. We do have some personnel issues, getting back to your thing. We have shortages, current and future, in both physicians and nurses. We're number 41 in the number of active physicians per population base. And by 2020, we're going to need an additional 4,500 nurses, and the number of new nurses that we're graduating each year is not enough to meet that supply. So if there are technology applications that help improve the efficiency or extend the reach of providers, you know, nurses or other practitioners, that's really good. Electronic communications, I'm spending a lot of my time here. Electronic medical records have the potential to improve quality and reduce costs. Clinicians have the information they need at the point of care, so they don't have to wonder about, what my clinical needs are. And I don't have to repeat tests if I can access the fact that it was done a few days ago at a different facility. GHA is a founding member of the Georgia Health Information Network, which is a statewide group connecting local electronic communications networks. And GHIN is actually alive now. It went live about 2 or 3 months ago, and data is actually being transferred between hospitals with different electronic medical record systems, and we have a queue of hospitals lining up to get in that. So this is some of the stuff that's going to help address some of these concerns. And then finally, my last slide, opportunities. Okay, what does all this mean to you guys? Well, care delivery is being transformed, and this gets back to what I just said. There's a greater coordination of care, greater alignment of incentives. Again, follow the money. People they behave in ways that they're incentivized to behave financially, and some of the really good things happening under the health reform law are that they're changing the incentives for how care is delivered. So that's really good. And there's both clinical and patient care management technology, which is reaching its maturity. I was at the HIMSS conference in Orlando about a month ago, and they're just very, very exciting, all the applications. I don't mean phone apps, but just, clinical and management applications that are available there. Population health management is the key to the future, keep people out of the hospital. And we're experiencing unprecedented financial stresses, which means we have to improve technology and delivery in an efficient way. So thank you. I think I've run over a bit, but I'll be around to answer questions later. So thank you.
Yeah.
Any more questions? Glenn. Yeah. We just wanted to give you a call about appreciation. Thank you so much. I appreciate it.
So some people might be thinking,
Yeah, if you want to contact me, by the way, my email is gpearson@gha.org. If anybody has something you want me to look at, let me know.
can we make this a picture?
Sure.
Okay, we'll send it out to you. So some of you may be sitting here and saying, so, why does that matter? That's not what my business does. I'm not an IT company, or how does this apply to me? But what we've learned over the past couple of years since we've had the program, that you really, really need to understand the industry, what all of the various and vast changes that are happening in the industry. You really need to understand what's going on so that you can readily identify and become familiar with the not only the industry but how your business can fit in the industry, because there is such a vast amount of opportunity. And this is why we have the panel here that we have today. And I'm going to bring up our moderator, Christopher Cunny, who will introduce our panel. Christopher is an executive information technology strategist at the senior level. He provides guidance and thought leadership specific to emerging healthcare technology offerings, compliance-related issues, technology adoption, and a myriad of other things. His recent roles include serving as Director of Emerging Healthcare Technology for AT&T, Vice President and COO for Health Innovation, and VP and CIO for Piedmont Healthcare. He currently serves as Managing Partner of Infinite Options. He's on a variety of boards. And he is the current president of the Georgia Health Information Management Systems Society. It's better known as HIMSS, or Georgia HIMSS, which is the industry's leading association. I just want to thank Christopher right now, because he has been a partner from day one since he met us and met the MBDA Business Center, that he's really committed. I just want to reinforce, as you know, our mission is to grow and strengthen minority-owned businesses, and we had, the focus of bringing more of our clients into this industry, and he has been committed to that. So thank you, Christopher, and come on up.
Good afternoon.
Hey.
While we're getting set up, I'm just curious, how many folks in here today are currently doing business with healthcare organizations, providers, payers, ancillary organization, ambulatory organization.
Raise your hands up high so we can see. Okay,
Oh, wow,
good,
that's
good,
quite a
good.
bit, a lot more
Yeah.
than I expected.
Mhm.
How many of you are members of HIMSS? Okay, we got to fix that. As Donna mentioned, HIMSS is what we like to think is the premier healthcare IT organization in the country. We have over 55,000 members. We're in every state in the country, in the U.S., and we also have chapters and affiliates in the UK, Asia Pacific, the Arab Emirates, and South America as well too. And as Donna mentioned, I serve as the president of the local Georgia HIMSS chapter. We were awarded Chapter of the Year last year, and Chapter Leader of the Year last year as well. And we partner with Georgia Tech, the Georgia Department of Economic Development, TAG, and other organizations to help promote businesses and innovations here in the state of Georgia. As I think someone mentioned earlier, it might have been Donna, that Georgia is what we believe is the healthcare epicenter of the universe. We really believe that. I mean, there's almost 300 companies that, and probably more, but 300 that we've at least identified that focus on healthcare IT. And that's companies like yourselves, but others like AT&T and Verizon, Samsung, UPS, believe it or not, has a healthcare arm, and others who focus on providing services to the healthcare space. So I wanted just to take a quick moment, if my panel would indulge me, and I know they've been very patient here, and just kind of set the stage real quickly. I know Glenn really gave you a reality check, right? I mean, healthcare is a tough industry to be a part of. I know you hear a lot of great things about healthcare and the opportunities that are there, and there absolutely are. But there are challenges, and so if you wonder why you're calling, you're knocking on doors of hospitals and physician practices, and they're not welcoming you with open arms, well, those are the reasons why. They've got tight margins, and in some cases they're losing money, and we're walking in the door saying, hey, buy my stuff too. And their lives are challenged. So we have to create opportunities for them to solve these problems. And I think we'll be talking about some of that today, but I wanted to also just kind of give you just a very quick, broad perspective on what's happening in the industry. So it's really an exciting time, and also a very scary time to be in healthcare. Lee Householder, the Chief Innovation Officer for GSW, says it very nicely in that 2014 is the year when where each of us are expected to be our own chief health officer. Whether we like it or not, that means we're expected to find our own answers, to make our own clinical connections, and help ourselves be healthier. And I think Glenn alluded to that earlier as well, too. We have to be accountable, just like our providers are. All in one of the most complex systems in the U.S. So the industry is really shifting away from episodic care and really incenting and compensating providers for episodic care to one that's focused around how to keep you healthy. And that's an interesting shift. When for over 100 years we've paid our doctors for paying them because you're sick, and now we're asking them to compensate them for keeping you well, and that's a complete shift in the paradigm. So real quickly, and I promise you this will take less than 10 minutes to go through, although it seems like a lot of bullets. Give you just a quick broad brush of what I believe is happening in healthcare. And there's much more than just this, but this is just my view of the world right now as well. So we'll talk about the other white coat, we'll talk a little bit about telehealth, and we'll be expanding on a little bit more, the rise of population health, biometrics, what I call app conversation in the exam room, innovation from outsiders, unprepared patients, the perfect payer storm, and digitally dependent providers. So real quickly, we typically think of our primary care physician as a guy or a lady who wears the white coat. But that definition of the care provider is really broadening for beyond just our traditional primary care physician. For example, our pharmacists are now becoming more actively involved in our care process. And so they're not just administering drugs anymore and giving you flu shots. Many of those individuals are involved in helping you manage chronic disease. They're becoming a part of your care plan. They're helping you manage the treatment and they're providing other services as well too. And so they are a direct competition in many cases to the traditional healthcare model. And so that means opportunities. How do you continue to support this capitalistic model that's starting to emerge as well? Can you provide services and solutions beyond this provider set? 2014 is also the year of telehealth. Glenn and I were talking about this earlier, and we've actually are potentially working on some engagements together as well, both here in the U.S. and outside of the U.S., where telehealth is really going to be in great demand. Because there is this shortage of providers in the healthcare space, we have to find alternative ways to take the existing provider population and extend their reach, especially in the rural settings. And so you look at things like psychiatric care, for example. If you go outside of Metro Atlanta to Southeast Georgia, Reedsville, Georgia, where I grew up, there's 2 traffic lights in that city, and I guarantee you there's probably not a psychologist there either. But yet the guy that's coming back from Iraq with post-traumatic stress that's going back home still needs care. And so how do they receive that care? They're using things like telehealth to provide consults and education to those individuals. And so you'll see more and more of that emerge over time. The rise of population health. I think, again, Glenn had mentioned, I think there was a statistic that said about 10% of the population actually contributes to 60% of the healthcare costs in this country, primarily because of chronic disease. And so we have to find ways to predict what's happening with certain demographics within our population and how do we treat them effectively so that these illnesses don't become a burden, continue to become a burden to the system. And so tools and technologies and resources and analytics and information to help manage segments of population will continue to emerge as opportunities for the industry. And then biometrics. I mean, this is the first generation of wearable devices like my gear, for example, that I have on. I'm a techie geek, and I tell you, it's an amazing tool too. So if you don't have one, you got to get one. We're moving away from just tracking our steps, how many steps we walk a day, to actually this thing can start measuring stress levels, it can start measuring your blood pressure, it can provide, passive information to our care providers so that they can proactively react to your care before an episodic event occurs. And so again, technologies that support that going forward will be in the forefront of the types of tools and technologies that hospitals and providers invest in. This concept of adversation in the exam room, more and more patients are becoming informed patients. And before they walk into the doctor's office, they've already collected data on their own care. They've either gone out to the web or they're tracking their own health in some ways. And they're walking in that exam room with information that they're giving their providers through applications like tools like the gear and others, passive monitoring devices. And so providing solutions that can help that care provider make smarter decisions about how they treat you will be areas of opportunity in the future as well. Innovation from outsiders, and I've been seeing this for at least 4 years now. I think truly the real change that's going to happen in healthcare, the way that we solve these problems going forward, it's not going to be through the traditional HIT companies. I'm sorry. There may be a few that bring some innovation, but it's going to be folks like you, folks who've solved these problems from other industries, who come from the airline industry, the banking industry, the manufacturing industry, government, who've had similar issues around how do you manage big data, how do you deal with security issues, how do you provide business intelligence to those industries, how do I use applications to manage my business. Those technologies are going to come from you guys. And you see it every day. The AT&Ts and the Microsofts and the Googles are not traditional healthcare IT companies, but yet they're introducing innovation on an ongoing basis. As educational institutions like Georgia Tech have foundries here. AT&T has a foundry here that's specifically investigating new technologies. Some of that is healthcare related as well. So that's the good news. I mean, even though there's this resistance that exists in healthcare to embrace, the outsider, it's the outsider that's going to change this industry. It fundamentally is. And then the navigation nightmare. There's a study that was recently done that said 1/3 of most adults in the U.S., 77 million, really have a difficulty navigating common health tasks, reading medication instructions, getting childhood immunization schedules on track, understanding how to treat a loved one when they're chronically ill. And this has a huge impact on this episodic care, these repeat visits. And so creating tools and technologies and solutions that help them navigate through this more seamlessly, more easy, will become areas of opportunity as well. And then the perfect storm, and Glenn talked about this as well too, is the payer model. It's influx here. Medicare, Medicaid are cutting reimbursement rates. The private sector is doing the same. They're holding doctors accountable for quality of care. And so that margin is shrinking. Not to mention, doctors are now holding pharmaceutical companies and others for providing drugs that actually solve the problem, not just mask the symptoms, because those are very expensive care methods as well. And so that storm is going to start creating, innovation and forcing innovation to occur as well. And so you need to be thinking about how you solve those problems. And then the digitally dependent care provider. That's you. That's your loved one. Unfortunately, both my parents have passed in the past 4 years through the chronic disease primarily. And the tools that I had to try to manage their care over time were limited. You're going to be faced with those same challenges with your loved ones, especially those who may not live in the same town you're in. How do you continue to provide care for them in the most efficient way? It's going to be through the use of technology. So I want to, that's my spiel. I want to take an opportunity real quickly to introduce our panelists and give them an opportunity to finally say something as well too. So thank you for being here. Thank you for being patient. I'm going to just very quickly read a couple of snippets of their bios, and all of them have very illustrious backgrounds and are very knowledgeable in their fields of endeavor. So I will not cover all the details, and I think their bios are available to you to read as well. I'm not going to read them necessarily in order. I'm just going to go down them real quick. Russ Ardillo. Russ is the Vice President of Healthcare for J.E. Dunn Construction. Leader in the commercial construction industry since 1921. Russ, who received a Bachelor of Science degree in construction management from the U.S. Air Force, has over 30 years of experience in construction. He is responsible for working with the project team to prepare pre-construction, budget proposals, value engineering schedules, and has completed construction projects from the design of a phase through the overall project implementation. Mark Cartwright is the Senior Director for Supplier Diversity for Novation. Mark Cartwright is the Senior Director for Supplier Diversity for Novation. He's earned his Master's in Business Administration and Finance from Virginia Tech, as well as a Bachelor's of Science degree in Management. He is certified by the Institute of Supply Management as a Certified Professional in Supply Management. Mark also among the first in the U.S. to achieve the Certified Professional in Supplier Diversity designation from ISM. Matt Jensen. Matt is the Chief Development Officer for Telehealth International Partnership. Matt is again, the Chief Development Officer for the International Partnership. He is currently developing new models of connecting care strategies with corporations, countries, and other health systems on an international scale. Jensen's success in the U.S. has applied telehealth initiatives and services under the Georgia Partnership of Telehealth, and is now focused on providing these cost-effective solutions here in U.S.-based and globally. Angela Wiltz. Angela is the Director of Supplier Diversity and Sustainability for Owens Miners. The largest distributor of brand name medical and surgical products in North America. As a Director of Supplier Diversity and Sustainability for Owens Miner, Angela leads the corporation's nationally recognized supplier diversity programs, partnerships, and strategies, working with numerous healthcare organizations, nonprofits, and government agencies and universities. And last but certainly not least, Deborah Williams. And Deborah is the Senior Director of Sourcing and Supplier Diversity for Premier Healthcare Solutions. Nearly 2,000, a Senior Director of Supplier Diversity in early 2008 based North Carolina company. Upon joining Premier Healthcare Solutions, William is responsible for Premier Supplier Diversity Committee, and under her leadership has launched and enhanced the program to include sourcing, education, and enrichment for diverse suppliers. A program aimed to increase the number of qualified, small, diverse regional enterprises on a Premier contract portfolio. Join me in welcoming our panelists today. So, thank you again for being here. Thank you for being patient. We look forward to hearing your commentary. So I'm going to ask just a couple of questions, somewhat open-ended, so I'll give you an opportunity to take them where you think your agenda might lie here. But the first one is a very simple one, and that is, what trends do you see in supplier diversity in healthcare? And I'll start with Deborah.
Oh, wow.
Okay. Don't touch the mic, you told me. Don't touch it. Nope.
Okay. Okay, my mouth is big enough everybody can hear me. I think Glenn and Christopher, kind of covered the landscape in healthcare very eloquently here, and after Glenn scared us half to death. Reality is always, the biggest dose that you guys need from a supplier perspective to help you manage your business. So, when we look at the changing climate in the healthcare industry, coding, reimbursement, coding, assistance and solutions will definitely be at the forefront, since a lot of the reimbursement is based on the way a hospital codes their services to third-party payers to get reimbursed. Outsourced services, solutions in certain areas such as food management, but more importantly, to Chris's point just now, IT. A lot of the capital equipment that's being used in the OR or cardiology suites are very, they're enhanced. They have a lot of IT capabilities to help that physician or nurse practitioner service the needs of that patient. Home health care services, ambulatory outpatient services will also play an integral part as the hospital shifts from being more inpatient focused to outpatient focused. And then last but not least, from a diversity perspective, we are in dire need of medical device manufacturers. A lot of the solutions that are provided to us, from a supplier diversity perspective in healthcare is driven by services, okay? And as you can see, the reimbursement, the margins are being driven by the services, and those services are tied to pharmaceuticals that are being administered to care for those patients, as well as a lot of the automated IT solutions embedded within the capital equipment that hospitals are using. So when you think about, what's driving the biggest percentage of the spend for a hospital, it's being generated through the manufacturing, of a lot of those types of products and equipment.
Mark or Angela, any additional thoughts on that question?
Well, as a distributor, this is Angela, with Owens & Minor, and I do want to share with you that Owens & Minor we have rebranded. We are taking a look at, based on what the industry is telling us, that we need to take a different look. We have to evolve traditional logistics, and that is where our focus is. And then how we're going to do that is to connect the world of medical products to the point of care. And the point of care is that provider and that deliverer of the healthcare services. So everything that Chris and Glenn have told you very soberingly, as well as somewhat optimistically, is what's on the horizon. And what we're looking at as a logistics, an evolved logistics company, is where do we fit in, where do you fit in, and how can we collectively get those products to the point of care through the appropriate manufacturing arenas, such as Deborah was sharing with you, and using the group purchasing organizations, and Mark is going to talk about his as well. We connect And it's a very different model than what has historically taken place in the past. And it's a new prescription, and this is what the futurists are calling it, a new prescription to health care. So we're looking at the docs, we're looking at the hospitals being global, because now hospitals that, even though you might be Georgia-based, you might have a hospital in Qatar, in Dubai, in England, or in London, and all over the world. So that is what we as a Fortune 300 company are having to look at and make the adjustments to. Our expectation, and I will shut up in a minute, but because y'all had me quiet for so long, it's good. But what we are looking at is how do we make that connection, and how do we prepare you to be able to make that connection with us? It's critical. The providers have to have patients coming in. The patients coming in under the Affordable Care Act look more like you and me than in the past, through the traditional means, through insurance means, and through all other reimbursable means, and the providers are not going to get paid unless we have the influx of patients coming in. We will not get paid unless we have we sell the products to the providers, and the GPOs won't get paid unless we pay them the services fees to get the products in through us. So it's a big connection. IT is at the center of it, and so it's a great time. It's a tremendous opportunity for you to be innovative, creative, and put your thinking caps on and come to the table with some new value-added propositions. I'm quiet for a minute.
Okay, yeah, so I would echo those comments, and actually there's a lot of contradictory forces at play right now. Because of the Affordable Care Act, we have downward pressures on the revenue streams. So if you think about it, many of the healthcare providers, they actually want to shrink their supply chain. That means they want to have a fewer number of contracts with a larger number of contracts with a fewer number of contractors. On the other hand, particularly with Novation, we have an alliance of academic medical centers. Most of those medical centers are heavily dependent upon research funding and government grants, or they're actually publicly owned. So as part of those grant requests, they require that you have a subcontracting plan with small businesses and diverse businesses. So whereas before Novation, we looked at a lot of the national contracts, we want people with national scale, but our hospitals, which are located in various regions, say we need to do business locally. So one of the things we're trying to do is identify those regional players and say it's okay if they don't want to have a national contract, if they only want to service the southeastern U.S. So it's interesting. Again, there's pressures on you to be more competitive as a supplier, but there's also some opportunities as well.
Thank you. And Russ, just to piggyback on that from a construction standpoint, clearly, and we were talking earlier about partnerships with primes, smaller companies looking for opportunities to do that so that they can get a foothold into these organizations. Can you talk a little bit about that from your perspective?
Yeah, we're seeing a lot more opportunities for minority and women businesses because the clients are requiring it more. In the past, they would just pick a few major GCs that they reputations and qualifications, and then you'd go down the road and build their project. But you're starting to require some participation by local and minority and women companies. So we've reached out as a company to some of the folks that are local in each where we have our offices, and trying to have a mentor program so that we can find out who they are, and they need help. They need to help figure out how to get there. When primarily I work on large healthcare construction projects, so hospitals, and you just don't start doing that. So we're starting to see some more opportunities for minority companies to come in and partner with us.
Right. And then, Matt, from your perspective, you're working now at the international level. What does that mean in terms of opportunity for small businesses, emerging technology companies?
I'd have to say that right now the space is wide open. There is a unique opportunity right now. What we do and what we've created here in Georgia is a great kind of nest egg for the rest of the planet to actually gain some knowledge from what we've been able to accomplish in Georgia. Now, when you think about healthcare progress or progression, Georgia doesn't come to the front of your mind. Okay, so we have to kind of think about that, but also think about how we've leveraged what we currently do, what I did for the past 8 years and what I've done with Georgia Partnership for Telehealth, and what we're doing now on an international level in about 5 other countries. We're starting to see a huge growth potential there for especially emerging developing nations. And Georgia has a lot of health disparities right alongside of a lot of developing nations. So we can learn a lot from each other. So we've traveled to China now, we've traveled to Guatemala. We have 5 sites in Guatemala. We have 1 site in China, starting a hospital network in Zambia. So you're starting to see a really unique collaboration across your medical institutions, across your clinics. Your physicians are more interested now in doing lots of different types of work. And and I always like to kind of show what we do, but and I'll get to that. I'm gonna show you some live eardrums and stuff, But Chris hit on some really hot points, and so did Glenn. When we start talking about healthcare innovation and what we need from outside industry, a lot of what we do and a lot of what I do comes from outside industries. Very little of it was ever created inside the healthcare environment. It's been adapted to it. The Fitbits, the iPads, the Google Glass, things like that. Those are coming in, and we're starting to adapt those to the practices. And healthcare is a little bit faster than our big healthcare system. Healthcare IT is a little faster than our healthcare system itself. And the ACA, I was in DC a couple weeks ago, meeting at the White House with some health IT advisors, and they are still about 10 years behind the flow of what the need is. So it's going to have to happen here. It's going to have to happen locally. It has to start locally. And then that model will progress. So I'm excited about it. What I do is probably one of the greatest jobs on the planet. I get to connect people on a day-to-day basis, kids from all over our state, and about 15 other states in our country, to psychiatric services that they couldn't get in Waycross, Georgia, or Berrien County, Georgia, or real small areas like that. And so that I see huge impact every day that I go to work. And I'm connected to a network of folks who can help me get there even quicker. So I'm excited about it.
Great, thank you. And we'll save questions for the end as well, too. We want our panelists to have an opportunity to share their thoughts. Okay, next question. Mark, from your perspective, what are some of the common mistakes that small businesses make when they attempt to solicit business from healthcare organizations?
I think it's the same mistakes that you see across multiple industries. One is not really understanding how that hospital or provider procures their services. And so you definitely need to do your research, because I think one of the most bothersome things for us is if you contact us or send someone an email and asking some basic information that's readily available on the website. So you write, Google is your friend, find out how to actually buy it, not only what they buy, how they buy. Just do an open-ended search to see what's in the news. That Premier went public, several months ago, to actually show that you've done your homework, because the data is really, there's no excuse for that. At some point, you're going to need more information. Sure, you can reach out to the supply diversity director, but again, find out how they buy and what they buy. Find out if they had a bid calendar. Do they issue an RFP? Is everything competitively bid? All those sorts of things you need to know, because you need to know how you can apply. Maybe it doesn't fit your model, so maybe you need to align with either another supplier to have more scale, or maybe you need to try to develop a relationship with a larger prime. So those are all the basics you need to know. Not only did you need to know your business, and pretty much everybody is technically proficient on what they do or what they provide, but what they don't know is how we buy. And I think that's a very critical piece.
Angela or Deborah, any other thoughts there?
Yeah, my thought would be to take what Mark said and then say, what is the value? What is your specific value proposition? So when you call me and say, all right, Angela, I've got ABC company and we want to do business with you. We're a woman or minority-owned company. Well, congratulations. I'm proud of it. We're certified, very good. Okay, now, what? You're not the only person calling me. I love you madly, but you're not the only person calling me. So what's in it for me specifically in terms of what's my company? You know, how am I judged or valued as a company? You know, we're a shareholder, we're a publicly traded company. So go do the research, find out what our value is. Where are we going? What's our focus? And then do the study with your value, where we're going, and come to me with a unique value proposition. You will get my attention. If you're coming to say, well, we can provide anything, what do you need to do? Well, no, thank you. Thanks for your interest, but that's not where we are right now. So do your research and come with your specific, unique value proposition. And after that, you will be heard, but don't expect a 3-month, 3-week turnaround, and that you'll get a contract and get this global kind of commitment. Because as Chris was mentioning, it's a 3-4 year out project for implementation of a truly unique and valuable proposition. So be aware of that so that we can manage your expectations. And it's not to say you should not have high expectations, but let's look at what is the value, what is the time frame. Put your intelligence and innovative creativity to work before you pick up the phone to call us.
Well, since my good friend over here called us out, Premier did go public September 27th of last year. And what I'd like to say is that as you're going through RFI, RFP processes, I'm often told or confronted with my privately held, certified minority women-owned companies like, Angela, I love you dearly, but I don't know you. So I'll give you this example. I'm courting you, right? So that's what the RFI, RFP process is about. We're in a courtship right now. I'm trying to figure out who you are, where we have synergies, what your price points are, what your service levels are. I want to know who you are. So when you tell me, when I ask, what is your last 3 years of revenue? I'm sorry, Ms. Williams, I'm in a privately held company and I'm not giving that information to you. Okay, you have every right to do that. But as a publicly held company, you doing your homework on me, you can go and access my annual report. You can see what my revenue is. You can see my balance sheet, my income statement, my forward-thinking strategy, all of the details about all of the different things that we do for our member hospitals across the country. But now you're telling me that you don't want to be that transparent with me. So when I get up to the altar and the preacher says, do you take this company to be your lawfully wedded company for the next 3 years? I'm like, well, they wouldn't share their financial information. They don't want to tell me who they're currently doing business with, how long they've been in business. No, I do not want to wed this company for the next. So just be very mindful of that. Once you get the business, start thinking strategically. So you've heard in every presentation here, solutions. You have to be able to come in and provide solutions to your prospective customer, which means you're going to do the homework, obviously, first. But when you provide those solutions, you have to think from a strategic perspective and stop thinking from a tactical. Hospitals are relying more and more on our suppliers to provide us with those solutions. So when you heard the conversation just recently saying, we're looking for those solutions from outside of our industry. I don't know if we're that far behind, but we are behind, with some of our technology and all of that. And we're relying on
based on what Matt's doing, we're way behind.
Exactly. I feel like I've been in this industry for 20-something years, and, I came in and I'm still trying to catch up. But we're looking more and more and depending more and more on our suppliers to provide us with those type of innovative solutions. And understand how to work with us to actually administer that. So, I would think that is some of the challenges that a lot of our small and diverse businesses, and last but not least, practice how to tell your story. I'm going to be real quick with this, Chris. I had a supplier call me. First of all, when I picked up the phone and said, good morning, Miss Williams, he put me on the defense. Your hospitals don't want to do business with me. So thank God I was working from home that day. I wasn't as stressed and I hadn't had too many cups of coffee. So So I said, okay, well, tell me what you do. So he told me he'd been in business for over 10 years. I said, who are you currently doing business with? He didn't name just local folks, U.S. based. He named global companies, Ford Motor Company, Chrysler, FedEx, et cetera. And I said, and for example, what was your sales volume last year? He said $180,000. So I said, okay, stop right there. I said, now put yourself on my side of the table. You're asking me to displace, stop doing business with a company that I may have been doing business with for the last 20 years. I rely on them, etc. And you want me to stop doing business with him and do business with you. And then when I think about what you told me, some things are not adding up, okay? So that old saying, practice your presentation in front of the mirror, but also listen to what you're telling your customer. Really understand how to tell your story and tell it to where you're differentiating what value you bring as a solution provider to that hospital wanting to consider you to do business with them. So, you know, that I'll end on that. So.
And I want to ask the same question, and I like the dating analogy as well, to Russ. As you're dating partners, what are some of the common mistakes they make?
Well, you know, it starts with, it used to be the clients always relied on us. Well, these hospitals now are starting to want to know deeper about us.
Yeah.
And our vendors, just like Deborah said, you know, a lot of times when we leave a project, our trades, plumbers, mechanical, electrical trades, end up working for the hospital well after I'm gone. So there's a relationship there that they want. But a lot of the same things, whether you're public or private companies, they're not prepared as well as they could be, and they just want to know why you're not giving them some work. So we try to coach them a little bit. I think that's what she was saying. You just got to give them the love a little bit more than just in the past where, well, you don't qualify, so you're over here. You try to help them as you're going through. At least that's what we try to do, because there are some great folks out there that have the wherewithal, but they just need a little fine tuning to get where it needs to go. And I'll tell you, some of the ones that we've built in the last 5 years have made us look great at our presentations, because you know they bring the power that these clients are looking for in our presentations.
I just want to do a time check. How much more time? Okay.
Yeah.
Of course you got it.
So, from your perspective in terms of actual experience that you said, you spoke about manufacturing, the medical device is one of them, and even for Russ, in construction, like we know, for example, that there's a move out of push healthcare out of the community, being more community care buildings being built as opposed to a hospital. So while we have a lot of IT companies in the room, we have other customers that can move to is trying to also understand like the manufacturing, the medical device, the construction. It might be other than a hospital. There might be some other opportunities that they can't readily, identify because when we're talking about that. So what are some of the other trends you see with regard to the opportunity landscape for
Yeah, see, well, the mobile health movement, and Glenn touched on this a little bit with mHealth, eHealth, iHealth, eClinical. There's all these new terms floating out there. It all falls under telehealth to some degree in my world. So I'm an integrator. That's what we do. We integrate software, hardware solutions from point to point. So we manage our own private cloud, and we do it securely through HIPAA compliance. And you're hearing some of this stuff right now at the FCC. They're doing some discussion around devices that are coming to market and what that tax may be on those devices. So when I was in DC, there was a lot of talk about that in relation to innovation clouding. It's clouding up innovation. It's not allowing people to get out of their garage because it's going to cost them too much to go to market. And so, you have to think about that. And you can't just run everything to the App Store anymore either. So if you're going to actually pull a diagnostic treatment plan off of a device or through a device, it has to be FDA approved and regulated. So if you have AT&T's Digital Life at your house, that's not a FDA approved platform. However, there are sensory programs that can go into the home now that are FDA approved, and there are companies out there that do that. So you have that consumer grade level product lines, and you have your business grade, or what I like to call business grade product lines, and then you have clinical grade product lines. So we have to dive deep into all of those. If I'm working in an ICU right here in Midtown with Dr. Buckman heads up 6 other ICU units all across the state from Midtown, virtually and remotely. He has patients on the grid from St. Joe's. So he can see oxygenation levels from his phone. You know, he can do these types of things right now through some of the products that are out there. And when I say 10 years behind, I wasn't being, technology's running a lot faster these days, and you talk about futurists out there and how they're applying it. You know, we're still working off of some of the data and some of the information that we've known and trended out for the next 10 to 15 years. But we're still not convinced that it's changing. And it's that whole standing in the fire and fighting the fire from within. There's a whole new payment model coming, value-based modifier. It is a unique opportunity for us to change the dynamics of healthcare and how it relates to us and the physician and crowdsourcing your care is not that far off. Hospitals, providers, healthcare communities, new healthcare communities, what you're talking about. We're designing new virtual communities. And you talk about, when I'm in Ware County, Georgia, or in Valdosta, Georgia, and I'm connected to a physician that may be in, Guatemala, and he may be giving me a secondary consult, or I may be giving a patient in Guatemala a secondary consult, or a consult. I see that. There's remote surgery going on, guys, right under our noses. So there's some unique things happening right around us, and we don't even really understand what's going on.
And what I see as the opportunity is to, if you just took one or two of the examples that Matt just gave about what his particular company is doing, what does your company do that can support, align, or enhance whatever it is that he's doing to give you an entree into that market? So it doesn't have to be the same thing, but every time you have a business, there is a whole bunch of other things in that supply chain that support that business. And where do you fit in? But the first thing is the knowledge of what's taking place in healthcare, which I see what MBDA is doing as a tremendous value to you. Christopher came to a symposium that we had, and Matt did too, and Donna last year, in it's a healthcare supplier diversity, same shameless plug, Alliance symposium that we give every year. However, the audience was blown away by what was taking place, what was on the horizon as it relates to healthcare IT. So those minority businesses went back and said, oh, have you thought about this, and da-da-da-da, and da-da-da. So for you as middle to large size minority businesses, what's your M&A strategy? If you are interested in getting involved in the healthcare supplier, in this healthcare supply chain, what are you going to bring to the table? Who do you need to buy, acquire, merge, or joint venture with in order to bring your product or your service to bear? So it's not startup that you're talking about. We're talking about where are you today, and you're doing your homework on what's taking place in healthcare, where it's going, so you can bring to us what your value is, and to the providers what your value is. And so that's where I see as the biggest opportunity, not as, let's bring some more supplies. Yeah, we need some surgical supplies, no tale about it. But it might be that the supply this pen looks like today is not the same pen that you will use for that procedure. You got the other one, see, 10 years down ahead of it. So let's talk about who's going to do the color, who's going to do this design, who's going to do it might be needing to be housed in a special package. All of those things, market it, who's going to sell it. So these are all opportunities for you as MWBEs to say, okay, if this is where this industry is going, and I want to play in that industry, I better learn about what's happening and where I can fit in and who I need to partner with in this room or outside of this room or across the country in order to bring that to bear. That's what I see as opportunities on the horizon.
And to Donna's point, if you look, you know, and IT, obviously, that's my world as well too, and I live in it, but as you look beyond IT into just maybe from a construction standpoint, what are some of the new emerging technologies or approaches that are happening now in construction?
Well, a lot of things that you're starting to see with the facilities folks, they, you know, it still sticks and bricks. When we build a facility, we still got to pour concrete, we still got to build walls. But, you know, Toyota, back in the 70s, when they came out with the Toyota Way, they put Detroit on their ear because when they were building automotives here in the United States, we were doing it very, you know, archaic, where they were doing it with robotics, and they brought a lot of that. Well, the construction industry is finally catching up with that. Lean construction, I'm sure you've heard a lot about lean construction. Prefabrication, where we're building head walls, and we're actually building, we did it here in Snellville, Georgia. We built 36 bathroom pods for Eastside Medical Center, off-site, completely built, tile bars, tile, mirrors, everything in them, and we flew them in. And there's less people on the job's cleaner, and it's a lean practice that we've gleaned from Toyota, but they came in and they were set right into place, and the doors, everything's on them, and it speeded up the schedule about 8 weeks. The owner loves it because he gets his facilities and starts generating revenue faster. And again, the job's safer, better quality because it's done off-site. Things aren't getting cut up and beat up during the construction process. So those are the things that we're behind on that we're starting to catch up on in the construction industry.
Before,
I will be quiet, Deborah.
my sister sitting next to me, I don't have to start pinching her. From a construction
There's so much out there.
From a construction perspective, what I have seen over the last 5 years is as the new hospitals are being built, the connectivity within the four walls of that hospital is being enhanced as they build it out. So I'm mindful of RFID asset technology tracking, wireless systems are also being installed as part of the construction project. So when you start talking about solutions that would provide some additional connectivity in that regard. The other thing I'll help you as IT professionals be mindful of, especially with electronic medical records being at the forefront of the Affordable Care Act. You know, when you look at the way you drive efficiency, I think Mark said it earlier, we're not looking to increase the number of suppliers. So when you're talking about open and closed structures from an IT perspective, if you are a software company or a software developer and you're developing software that lends itself to a closed structure, it's not able to talk to other systems in an open type way. You're now telling the customer they're going to have to incur a lot of money on the data integration coding side in order to do business with you. Okay, so just be very mindful that when hospitals are looking for solutions today, they're looking at how to integrate your IT solution into an existing technology that's already there. Okay, and so unless you can bring that type of solution, and also, you know, look at the construction as being at the front of the process, because as they build out these new community-based hospitals, I'm mindful of hospitals that I've been into that look more like resorts than they look like hospitals. Okay, Ritz-Carltons come to mind when I walked into one out in California. So, you know, you just got to get a little bit more acquainted with your prospective customer and look at the different entities that are out there to see how you can provide a solution to help them better service their needs and address the growing financial issues that they're going to be challenged with.
Right, a couple of things. So I guess another result of the recession, instead of maybe building new hospitals, hospitals are trying to to hold on to what they already have. Just like you might have a car in your garage and you've had about 10 years, but you said, I'm gonna hold on to it another year or two. So there's gonna be a lot of opportunities on the renovation side, from a construction standpoint. And also then on the energy management side, or what they also call performance contracting. So when I was in the state of Virginia, we put a contract out where basically the firms would come in and say, we guarantee you on this particular facility that we're gonna save you X number of dollars a year. And if we don't deliver on those savings, because we have a bond, we're gonna reimburse you for that difference. So I think you have to look at those opportunities. Then the other big opportunities is on the analytics side. From innovation, even though we have contracts, our other big tool now is analytics. Really following every dollar down to the last penny. And this is how your money is being spent, and this is how we can save you money. So if you have an IT firm, you're just a smart guy, there's a lot of analytic tools that they need. It's not some analytics doesn't cost a lot of money up front. If you wanted to be a manufacturer, you have to have capital, you have to have capacity, you have to have money. But your analytics is more intellectual capital. So take advantage of those opportunities.
Yeah. Well, you know what? When we say medical device manufacturing, let me tell you how the big guys do it. Do you actually think Johnson & Johnson and GE actually own and operate manufacturing facilities to produce the products that they sell, either whether it's in the retail or hospital market? How many of you think that they own all of those manufacturing facilities? Let's see what they're doing. NAFTA. When NAFTA was signed into law, it gave every manufacturer, starting with the car industry, because I was in Detroit at the time, they outsource and develop contracting relationships with manufacturers in China. Now, they may have the expertise within their companies, like a Johnson & Johnson would. They'll have research folks that'll say, I want my product to be built based on these specifications. Hospitals go to a construction company. I want my hospital to be built based on these specifications. They hand it off. They do a proposal to these various manufacturers in China. Whoever comes back with the best price gets the contract. That manufacturer then is responsible for manufacturing, and they'll monitor, Johnson & Johnson will monitor that manufacturing facility for quality and all kind of FDA requirements that they have to adhere to for their product. That manufacturer will then put the label on it, ship it over here, and Johnson & Johnson, it's trademarked under their label, and they sell it to us as consumers, whether we're patients or consumers going to Walmarts. So when I talk about medical device manufacturing, that is a strategy. So I can appreciate that it is a high cost to enter into manufacturing, no matter what industry it is. Real quickly, when we had the economic downturn, the biggest, the manufacturers that were impacted in Detroit were exclusive manufacturers for the big three. And as we all know, the big three in 2008 was, some of them, Chrysler in particular, was underwater. They had to reduce the number of manufacturers. Our hospitals in Michigan tried to help those manufacturers diversify their manufacturing capabilities to include medical device manufacturing. And some of the solutions that were provided enabled them to go and have subcontracting relationships to give them the time to retool and the money to retool in order to start the medical device manufacturing. So there's other ways in which to enter into manufacturing type of relationships or develop those type of strategies.
And those component parts, from kitting to doing all of those other things from the other from this external industry expertise coming in, that is where there is a tremendous amount of opportunity for those of you in this room.
Right.
So, put your thinking caps on, talk to each other, talk to us, do your research, check with Donna as to where is this, what are the opportunities in the industry, see where the downturns are, what the providers are looking for, and, get busy. You got to get on it, and you can't just hit one time and think it's going to all fall in your lap. It will not. You have to stay very aggressive about your search and what expertise you want to bring to this industry.
So I want to ask one final question and then give Matt an opportunity to do his demo as well, too, because I know you wanted to do that. It's a very interesting technology as well. as we talk about, meaningful use, now, how many people in the room have heard that term and really understand what that means?
I'm sorry, I didn't hear.
Meaningful use. Okay, just a handful. So you hear this term a lot. It's all a part of, the our funding and High-Tech Act and holding organizations accountable for using technology within healthcare the appropriate way. And I put up on the screen here, and for the sake of time, I won't read it. But if you have questions about it, you can. But the question I wanted to ask the panelists is, as you see what hospitals are struggling with to meet the meaningful use mandates, what are the opportunities from your perspective that companies like the ones here can help fill some of those gaps they may have as it relates to meeting some of the meaningful use mandates, for example, like engaging patients or safety and privacy and interoperability, things like that?
At Premier, we're one of the GPOs, because I don't want to exclude my partner over here. Premier, one of the services that we provide to our hospitals includes what we call population management. And that solution, we have the biggest clinical database of, representing clinical data. Since we represent about 57% of the acute care hospitals, that kind of equates to about 1 in 4 patients, clinical data that we have in our database. And so we work with our hospitals not only to provide them access to our contracts that we negotiate competitive pricing with medical device manufacturers on, we also are able to go in and work with them on a consulting level to help them understand, okay, your clinical solution that you're driving through your OR, is that driving efficiencies? How does it impact the quality of that patient's care? Once the patient is released, I think you heard Glenn say earlier, if the patient comes out of our hospitals and has to be readmitted within 30 days, they don't get any reimbursement for that, okay? So we had to figure out readmission or how to address that from medication adherence, depending on what you were treated for. We have now a solution that provides our hospitals with staffing capabilities to call patients after you leave the hospital to make sure you're taking your medication, you're doing that activity. And these electronic solutions through telemedicine is going to monitor if you're a diabetic or a congestive heart failure patient, for example, you get released. We're going to make sure you're taking your meds. And we're going to help you monitor how much water gain you're building up. And if we need to, have you do something else different. So we as a GPO provide more than just group, contracts to our hospitals. We actually work with them through our Quest program. We have about 277 hospitals that actually monitor a lot of the different core objectives that's under the meaningful use policy to make sure that our hospitals, and to date, just to read some statistics, our hospitals in this program have saved over $3 to $5 billion since we launched the program in 2007. Okay, so we're helping our hospitals make a difference in the way that they deliver health care, but more importantly on the quality of care that they're administering.
Yeah, I would echo the same thing. One of the things as the economy gets tight is you have to diversify and do different things. And so the GPOs, including Premier, Innovation, Med Assets, we're diversifying as well. So a lot more of our revenue is actually coming from non-contracting type things. And to Deborah's point, like we used to do follow-up, but it was more like a customer satisfaction survey. Hey, how was your stay in the hospital? How was everything? Well, that's really no benefit at all. Right. Now it is, are you taking your medicine? When you're taking medicine, things such as that. So I think those are the spaces you need to be in. A patient aftercare, you don't need to be in a clinician for that. We do have clinicians on staff. We have doctors. We have pharmacists. We have nurses. But there's a lot of things in the patient care support that you don't have to be a medical healthcare professional. You need to find out what they are.
Any final thoughts, and I'll turn it over to Matt for his demonstration.
Just, real quick, the benefits of construction for meaningful use is, what is the value to the client at the end? It used to be, the architects designed the whole building, and then they gave us the drawings to price, and then if you were selected, then you built Now they bring us in way early. We're part of the design team, and then that's where we lean on our vendors, people like you, to come up with the ideas and how we're going to build it better and faster and with more quality. So that's how it's affected us.
From the distributor's perspective, our biggest impact on meaningful use is through cost reduction and improved operating efficiencies. And because we do 3PL, we do med-surg supplies, and that's where the medical devices and manufacturing of med-surg supplies come in through you, and also providing physician services. So we are moving into, based on the Affordable Care Act, we're moving into the communities where these new, where Russ is talking about the new physician's office are being built. One other component of that, in reference to what Russ said, I have a client that for a modular design, because of the turnaround in limited turnaround time for physicians' practices, this client designed an exam room based on the demographics from that particular population that was being served. So if you have certain ethnic groups that are predisposed to obesity, hypertension, the exam room comes in with the heavy built tables, with the tables that hold extra weights, the larger scales, and staffed with those kinds of medical and surgical products that support that population. Opportunities for that, meaning what are you bringing, what are your products, what can be served, and how do you package that and load it onto the truck and get it delivered to the area. So just as a thought, those are some of the things that we do to reduce cost and also to improve patient care and outcomes.
Okay, so I have a kind of question for you, Angela. I think a lot of people probably in healthcare don't really understand the distributor role, what the distributor does. And are there opportunities for smaller firms as distributors in healthcare?
Yes, there are. As long as the costs are meeting the cost reduction, you don't want to layer cost. But yes, there is tremendous opportunity within the local areas to distribute medical and surgical equipment and supplies. But the margins are down at that lower end. So there are other, I always suggest other kinds of opportunities, but nevertheless, let's not rule that out, because if you have a way of doing it faster, better, and cheaper, then let's definitely talk about it.
What I will say from a GPO perspective, because while there is opportunities, the margins are low, I would ask you to do your homework to confirm what these distributors currently provide to the hospitals today. As hospitals have shifted to prime distribution relationships, it's more than just inventorying the product and dropping it off on the hospital's receiving dock. We've shifted the cost of that inventory to the distributor. They're managing it in low unit of measure type of relationships with those hospitals down to the department level. They're providing additional consulting services as well. So it's
tracking
more,
and reporting and analysis.
Electronic invoicing, the whole 9 yards. So, you know, just to say I'm a distributor and I got 200,000 square feet, the value of my warehouse inventory is $2 million is not going to be enough. Okay, so just do your homework to understand what the two prime distributors in this industry are currently providing to the hospitals, and the two biggest in this industry is Owens & Minor and Cardinal Health.
Let's take a question. Okay. All right, well, I wanted y'all to meet Kelly. Kelly's live right now. So
hi, Kelly.
hello, Kelly.
Wow, she's so quiet.
Yeah.
Everybody here, Kelly? Say hello. There you go. All right. So Kelly is actually in Ware County, Georgia, or Waycross, Georgia. Is everybody familiar with Waycross, Georgia? Southeastern corner of the state. She might as well be in China right now, because that's where we go from her office, you know, for training and stuff like that right now. She actually provides training to a lot of our sites. So I'm going to turn it over to her real quick. She's going to show you a couple images, and this is what we do in our network right now. We train physicians, we train providers, we work with hospital systems, we work with development companies in integration and integrating into this vertical. So, Kelly, I'm going to turn it over to you. Show us a couple of your body parts real quick.
Okay. I am sitting in front of a full telemedicine cart, and the most important piece I have in my hand is this AIO scope. It's an all-in-one, and that's what I'm going to show some images with. Certainly doesn't have to be on a telemedicine card. This could be on a laptop as well. Let me show you. I warn you, if you're at all squeamish, you're about to see the inside of my ear. And the parking lot. So that is the inside of my right ear. I'm going to show you my throat for the next image. This camera is very easy to use. If I can do it, anybody can. I'm just going to detach the tip. And I'm going to put on a spacer bar real quick. Many times the spacer bar is used for dermatology consults. In this application, it's used simply to help me hold the camera still.
You'll notice that this camera and what she's doing, this isn't just for remote medicine. Actually, it can be used in a hospital for a regular consult. So the idea behind that is it's a teaching tool now. So you bring this into the exam room with the patient, you can now see what the doctor sees. You can now be a part of what's in the box, so to speak. And it becomes, a lot of our patients don't have access to specialty care, let alone primary care. So when they see this for the first time, and they see their eye, or they see a lesion for the first time magnified, and then the physician sometimes, this is the first time he or she's been able to see it in high def because their eyes don't work as well as some of the digital technology. And then you capture it, right? So you steal that image and you hold it, and you can now push that image wherever it needs to go. It needs to go to the medical record, or if it needs to be shared with someone, another specialist. You know, this is about efficiencies, right? This is about filling in the gaps, and then also getting rid of the mundane, right? Because when I was speaking to a friend of mine who's a radiologist, he's been doing it for years, and he said, Matt, I've created a system that gets rid of the mundane tasks that I have to do. Now I can read all over the world twice, if not 10 times faster, and then more efficiently and more effectively now that I have some of these new tools. So that's what I go talk to physicians, I go talk to hospital administrators. Now I'm talking to the Minister of Health. When I go to Macedonia, I'm not talking to the hospital administrator anymore. I'm talking to the Minister of Health, because you're working with the whole country. You know, it's not a small thing anymore to them. This is big. This is a big deal. And a lot of developing countries will leapfrog the U.S. I know Glenn just left. I'm sorry. I can talk about him now. But they will leapfrog us because they're built off cellular infrastructure. They're built off of using technology. They're going to get there quicker in some cases, and already have in some cases. So, and you see she captured those 4 images. I won't go into too much detail, but you can do heart and lung sounds. And of course, you guys were talking about Google Glass, and we're testing these right now in our network. And you talk about efficiencies, you talk about augmented reality, you talk about some of the businesses that are in this building. Merlin being one of them, came out of this building here. Augmented reality, becoming more efficient so that you can take the mundane out and they can get back to practicing. You know, the supplier change, everything that's wrapped around has to become seamless, integrated, interoperable. Thank you for that opportunity, Chris. Thank you.
That is phenomenal.
Bye.
Thanks. Bye.
Any time for questions at all?
Anybody have any questions?
I know this gentleman raised his hand earlier.
I just have one, primarily for Premier Health. You know, playing devil's advocate and being in the real world, you know, I want to get an understanding of what your take is on biases when you mention subcontracting. Though we're not, my organization, Phantom IT, is not 180,000 revenue, but we are between 1 and 5 million. So we're not considered big box. I want to know, first of all, do you feel that there's biases when you have an MSP in your organization that has to bring in subcontractors? And what do you do to manage those biases so minority-owned companies can get a better footing on how to get a hold of some of those contracts that are lingering out there?
I think we all have biases in everything that we do. I think what you, as small businesses, need to make sure you're doing is telling your story in a comprehensive, but more importantly, in a transparent way. So if you're having to subcontract, obviously for Premier, we wouldn't have the contract directly with you. We would have it with, the market share leader. And then, you working with the market share leader would have to figure out how to work with that that company to make sure that they understand, you know, that you're doing business with them. If you want to represent yourself as a tier 1 and develop those subcontracting relationships to give you the scale that you need to manage the project, again, just be transparent about it. You know, so that way the customer, or more importantly, the GPO knows, okay, when we go to our committees to review your company with our committees, they understand, look, this company is small, but they've partnered in a subcontracting way with X company to help be able to manage, you know, the capacity that we know premier hospitals can represent to that company. So I think the bottom line is just be transparent. And don't let them discover it on your own, especially if you've done something or have not done something you were supposed to, like follow up and deliver, you know. So I think it's all good. You just need to be transparent about it. Did that answer your question? Sort of, yeah.
Lawrence Elliott with Extension. I was just wondering, after listening to all the very well spoken speeches, thank you for your time, how can, and this is speaking out loud, especially in reference to your point about intangible services, maybe expertise, maybe that being an entree of being able to develop relationships and applications with the value proposition when it comes to regulatory. With emerging technology, there also comes the need for migration and upgrade and infrastructure and different types of technologies to be laid upon that infrastructure. And at the same time, when you make changes, you have to make sure that those changes are compliant with the regulations that we implement and such. Could that be potentially from a small business perspective, an entree, a way to establish relationships with either one of them?
Okay, I don't know that I understand the question. I understand regulatory, but are you saying that that's what you currently do and you'd like to offer that?
Yes, I am.
Okay. If we have a category for it, we'll consider you for a contract to do business with our hospitals. If you're currently doing, it would be nice if you are currently doing business in the healthcare industry. So that way you can actually provide references that attest to the value that you're driving through, you know, the services you actually, you know, administer.
Yeah, I just wanted to comment also. My company actually provides privacy and security assessments for healthcare organizations. And so we do that assessment work, and then we work with them to do the remediation of it as well too. So but
exactly.
Yeah.
And when the audit's coming,
yeah,
that's going to be big.
Yeah. Exactly.
First, digitizing the medical records and things like that.
Like, as much as we talk about Big Brother, we complain about regulatory, especially new things, it really creates opportunity for the right firms. And you see some firms are already they see that coming down the pipeline, because these things don't happen overnight. They would talk about in the legislature for a while. You see them out in industry news. You go to these conferences and events, and it's like, okay, we're going to get there eventually. Right. So instead of fighting, they said, okay, we're going to get there. Right. Be proactive and deliver a solution.
Quick question.
I'm not stopping the conversation.
I just want to follow up. I think, you know, to the point specific to forward-thinking strategies, when you hear about all of the stuff that's happening within this industry, what I am mindful of is that when we do our business line reviews with our suppliers, they're not coming in telling us about these forward-thinking strategies. Some of you may not even be building it into your infrastructure today. For example, when I say, you know, from a resource perspective, you're not positioned to be able to even grow incrementally, local, regional to national. And I'm mindful of an example that I sometimes use. When I was growing up, I wanted to be a doctor, right? Well, once I became 21, 22, I couldn't walk in the hospital and say, you know, my childhood aspiration was to be a doctor. because I don't have any credentials. I didn't prepare for it. I didn't go to medical school. I got no learning, nothing, no degrees or anything. But yet and still, I want the hospital to employ me as a physician. So what I use that example with businesses. Instead of managing your infrastructure based on what you currently have today, think about it in 3 to 5 year increments. So if you want to go from a $500 or $2 million company, and in 3 to 5 years you want to grow to be $5–10 million, you've got to do something in your infrastructure today that helps you get there. You can't wait until you get to 10 million, because by that time, you'll never get there. Yeah, exactly. Thank you. I was trying to say that very delicately. A lot of companies say, once I get the contract, I'll add those 10 people. And I'm like, no. It's not good. It doesn't work that way in healthcare. We expect that when we give you the contract, you can hit the ground running to implement and sell us the goods and services.
You had a question?
Yes, mine is around value and cost reduction. Are there obvious conflicts when you're talking about keeping patients well versus healing the sick? There's some persons that are leery about what's going on here. Can you?
Absolutely. I think, people equate quality with cost. Like, it costs more, so it must be better. So, you don't want to, you can't skip on quality. You have to have standards. And I mentioned something earlier about the value-based modifier and how it's written into the ACA, and how we're just like meaningful use 2, we're still trying to figure out what that means, even though it's meaningful. We're trying to figure out how to apply that, right? So words in action are always different. There's a book out there called The World's Flat. It's flat, but it's only about a mile wide right now because of the technology that's available to us today. So there's smaller margins of getting into this space. So you have to be really innovative or really creative in your partnerships and how you link them together. But for patients to have access to what you just saw, policy-wise, payment-wise, technology-wise, safety and security has to be in the forefront of everything that you think about in relation to, caregiving. Yes, you can. There is a. Some people think that what I just did looked pretty simple because I just hit a button, called in, and bam, she started doing. There's a lot of complexity behind, but it doesn't have to be complicated. We tend to complicate things. We're good at that. So think about that. I think that's how I think about it. When I go in to talk to a hospital or a physician's office and they want to go with their local broadband, and they want to connect with, into their patients' homes, I'm saying, we can do that, but the variables won't give you the quality that you need unless you do it this way. And then we figure that out. We have the equation, we have the equipment, we have the construction and the infrastructure to do it, but the cost might be a little bit higher on the front end. So you got to think about that, okay? And what's the value-based add in relation to how I'm going to serve my patients? Your physicians will be graded. You will be grading your physicians in the very near future. I'm talking like 2 years out. That's part of that value-based modifier. They did kick it down the field a little bit further recently with the Doc Fix bill that's going through right now. So they kicked it down the field maybe another 20 yards, but it's still going to happen. There's a seismic shift happening in healthcare right now. And I know y'all feel it.
Yeah, we do. And how we've been measuring that, quality and cost, for example, to your point just now, the product may cost a little bit more on the purchase side, but if you can demonstrate through clinical studies that using your product actually lowers the cost overall for the hospital. So it's those clinical outcomes that are going to marry back up to the quality of the product that is going to offset that additional cost I may have had to purchase the product at on the front end.
And so with that, we've got some other opportunities for us to dive a little deeper with the panel. First of all, I just want to say that as you can see, this is really beyond complicated. I think Matt said it really appropriately when he said there is a seismic shift, and it's not going to happen. We're already like in it, and so the shift from to a consumer model is really important for you guys to understand for your business that this is real and that this is happening now. The panel here have, first of all, I want to thank them for their time. They have a tremendous amount, not only of wealth of information and experience, but commitment to you, but also to MBDA and MBDA Business Center to partner with us to help you move further into the industry if you already are, or if you're really, really, truly interested in getting into the industry, taking the necessary steps to do that. So I really thank you for that commitment. I wanted to continue to impress, you know, the need for you, as with any industry. I mean, most of you are our clients, so you know I know how you operate. When you go in, you're in. And so just becoming immersed in any industry new is critical. I want you to, you know, think about, to the extent that you can get ahead of the curve in your industry, you know, and I think Angela gave some really great examples of in the manufacturing, both of you did, in the manufacturing and all of the supply chain around that and how important that is. So that will be another area that we'll be exploring. And then, you know, we have relationships with the panel. We're here, they're here to help develop relationships with you. So with that, I'm going to move into our next session of the meeting. And we're going to take like a 5-minute break. Before we do that, the panel have committed to staying here to do some more what we're calling a little speed networking, where you can talk, introduce yourself, kind of swap cards. Alicia's going to come up and give you some instructions about that. After that, we were going to do 3 rounds, but in the interest of time, we're going to do 2 rounds. And after that, we're going to adjourn up the street to the Barrel House for yet some more networking. Over the years, again, we're building on our 10 years. What we've heard from many of you is, you know, we want more time to not only network with guests, but with each other. Because we've learned from our healthcare program and others that the network, you know, we've got outcomes now of just our companies getting to know each other better. And that's something that we're going to be doing a lot, at least once per quarter, is offering these types of opportunities and then doing what we call a little social capital networking so that you can really get to know each other better so you can do business. That's what it's about. I'm going to leave, so I'm going to turn it over to Alicia. I've got a family commitment that I've got to be somewhere by 4:30, 5 o'clock. But I'm going to leave you in the appropriate hands of Alicia and Yvonne and Maria and Brandon Miller, who is our current biomedical engineering student here at Georgia Tech, who's graduating in May. And they will shepherd you and everything along the way. I'm still going to hang around. Thank you.
Okay, first, so we're just going to break for just like 5 minutes. We have some more water, some snack bars and stuff like that just to keep you going. Oh, is it up? Can you hear me?
Yeah. Now.
Okay. So we're actually going to just separate the room into 5 sections. This is kind of how the table